Bom dia, muito bem-vindos todos os nossos estudantes, cirurgiões dentistas e professores que estão participando desse evento, um evento internacional da nossa instituição. Sejam todos muito bem-vindos para a nossa palestra internacional sobre um tema de cirurgia bucomaxilofacial denominado Melhorar a forma facial usando movimentos maxilomandibulares rotacionais. Sou o professor Eduardo Calil, coordeno o curso de Odontologia da UNG atualmente e tenho o enorme prazer em estar participando da cerimônia de abertura do nosso evento. Queria agradecer inicialmente a nossa professora Eliane Queiroz, professora do curso de graduação em Odontologia da Universidade de Guarulhos, que foi uma grande incentivadora da criação da nossa Liga Acadêmica de Cirurgia e Traumatologia Bucomaxilofacial, representada aqui pelos acadêmicos Felipe Mazzini e Lauren Aragão. Muito obrigado, professora Eliane. Muito obrigado também ao professor Leonarod Faverani, lá da Unesp, que vai abrilhantar também o nosso evento, a nossa palestra. Na sequência, eu quero agradecer também o Fabiano Soldati, funcionário da nossa instituição, responsável pelo setor de extensão. Sem ele, não seria possível a viabilização desse evento. Agradeço, na sequência, o professor Dr. Igor Berenguel, coordenador do Serviço de Cirurgia e Traumatologia Bucomaxilofacial do Hospital Regional Sul de São Paulo. Muito obrigado, doutor Igor, por dispensar o seu tempo, os seus ensinamentos para o nosso evento. E também ao professor Stevem Sullivan, da Universidade de Oklahoma, que também é uma presença importante, marcante, principal no nosso evento, que também se disponibilizou a passar um pouco dos seus conhecimentos sobre o tema para os nossos profissionais e futuros profissionais de odontologia. Muito obrigado a todos, tenham um ótimo evento, tenho certeza que o evento será muito enriquecedor para todos nós. Muito obrigado. Eu passo a palavra agora para o professor Igor.
Um ótimo dia a todos, e um motivo de felicidade aqui, eu agradeço a oportunidade através da colega professora Eliane, dos professores Léo Faverani, também do professor Calil, pela introdução aqui, pela apresentação e utilização aqui desse canal. E, em especial, o professor Sullivan, que gentilmente aceitou o nosso convite para estar falando sobre cirurgia ortognática hoje, né? E o tema da palestra aqui, como já foi dito, é melhorar a forma facial usando movimentos maxilomandibulares rotacionais, que é um tema bem atual, né? O professor Sullivan, em 2013, eu tive a oportunidade de ficar uns 15 dias em Oklahoma, e por lá fui a alguns hospitais, junto com ele, com a equipe dele, os residentes, o Kevin Smith, e outros profissionais que lá estão, e me receberam assim de forma extraordinária. São pessoas extremamente gentis, e tão logo fizemos o convite, eles aceitaram, ele aceitou prontamente para estar falando conosco, né? O Sullivan é o chairman da Universidade de Oklahoma, né? Ele é professor de ciências cirúrgicas da Faculdade de Odontologia da Universidade de Oklahoma, né? E ele terminou o seu treinamento em odontologia na Faculdade de Odontologia de Baylor, em Dallas, no Texas, em 1983, e completou a residência em cirurgia bucomaxilofacial em 1988, em Oklahoma. E das suas experiências internacionais, ele ficou um período no West Scotland Plastic and Oral Surgery Unit da Universidade de Glasgow, na Escócia, e também ele foi fellowship do Royal Children's Hospital na unidade de cirurgia plástica em Melbourne, na Austrália. E atualmente ele é chairman do departamento de bucomaxilo da Universidade de Oklahoma. Iniciou essa atuação em 1992. Ele também, dentre as suas atribuições, ele faz parte do comitê examinador do American Board of Oral and Maxillofacial Surgeons, e também é presidente da Sociedade de Bucomaxilofacial de Oklahoma, né? E a sua principal prática está em cirurgias ortognáticas, né, na correção das deformidades dentofaciais e também em reconstrução da articulação temporomandibular, né? E o Dr. Sullivan comumente realiza conferências desses tópicos, tanto nacionalmente quanto internacionalmente. Então, agora eu vou introduzi-lo aqui a todos, introduzi-lo em inglês, né, e passo a palavra para o Dr. Sullivan. So, Dr. Sullivan?
Yes, Igor,
Okay.
thank you so much.
Okay, thank you. It's a pleasure to have you with us today. Thank you so much for your support and dedication. We are honored to have one of the best surgeons in the world here with us. Thanks for sharing your knowledge. We appreciate it too much. You can start the lecture. Enhance facial form using rotational maxillomandibular movements. Thank you so much, Doctor.
Thank you, Igor. I appreciate the opportunity to be with you. The morning started off a little bit hectic trying to get this new technology to work.
Okay. No
we're unfortunately running about 20 minutes late, which a good 10 minutes, that's my fault.
Oh, no problem.
Being able to get the StreamYard to work, but it's a pleasure to be with you.
Okay.
And I welcome the opportunity to visit with your group.
Okay, thank you so much. We are in our audience here today. We have specialists, masters, and even a lot of students in the University of Guarulhos in São Paulo.
Very nice, thank you.
Okay, thank you.
Are we ready?
Yeah, you can start.
All right, thank you.
So Doctor, we have Leo Faverani, is a professor in UNESP, you know. He's friend of Fued and Professor Gabrielli, you know.
Nice. Yes.
Very good guy, very nice guy.
Nice to meet you.
And he will be our moderator.
Very good.
This morning, okay?
Very good.
Thank you.
Thank you so much. You can start. Thank you.
All right, thank you.
Thank you.
Well, I didn't understand everything in Portuguese, but I think Igor transmitted to you that my practice is largely corrective jaw surgery and TMJ reconstruction. I've had the pleasure of having a number of Brazilian surgeons come to Oklahoma and spend anywhere from a week to 2 weeks with me on some even more than once, observing and seeing some of the techniques that I use for corrective jaw surgery. And I've kind of developed a philosophy over the last 30 years or so that's evolved, which most, I think, surgeons do have an evolving philosophy of treatment. But I must admit that one of the most important individuals in my professional development is my dear friend, Johan Renneke, who practiced in Johannesburg and then Cape Town, and just this week moved to Amsterdam to live. Johan and I have been friends for about 20-some years, and he has influenced me greatly and really brought me to understand the importance of rotational movements. Now, I've been using counterclockwise rotations for probably close to 30 years, but I really didn't have the firm understanding until about 20 years ago on what one could accomplish with these surgical movements, as well as the importance of incisor position. And we're going to talk about that today. As Igor mentioned, I am from Oklahoma, which is right in the middle of the United States. It was founded, as you'll see here, in the 1880s when there was a land rush and people homesteaded and claimed their land. Now Oklahoma City is a thriving city of about 1 million people, with a state population of about 4 million people. We get some incredible sunsets, but also some unbelievable weather, including tornadoes, which can be quite spectacular to watch, but at the same time, unbelievably devastating, leaving a tremendous amount of destruction in their wake. But they don't happen very often, usually in May and June of the year, and this year was a very quiet year, but it's something we're oftentimes noted for. Everyone has a philosophy in orthodontic surgery, and mine is the face comes first. I think that it's very important that that orthodontic surgery be aesthetically driven. And to me, to make the face look good, the key is ultimately the maxillary position. It determines the smile line. It determines final chin position and the elements of the profile. So it's a bit of art and it's a bit of science. The science is the orthodontist placing the teeth in the best positions, and then the surgeon placing the skeletal structures in stable and normal orientation. And if you do those two things, you usually get a very, very pleasing aesthetic result. I look at it philosophically that the maxilla is truly the aesthetic unit of the dental facial complex. The maxilla dictates the final mandibular position, except it does not dictate the final position of the chin, because as we know, we can always do a genioplasty and make that the ultimate change. It's somewhat important to understand the occlusal plane, and the mandibular, the maxillary incisors are the most anterior aspect of the occlusal plane, and so where those teeth are positioned vertically will make a very important aesthetic statement as you develop the smile line when you begin manipulating the occlusal plane through rotational movements and also manipulating them through vertical and any type of vertical change. The rise of the occlusal plane posteriorly is really important, in my view, to add to a harmonious smile line. Bill Arnett's a very good friend of mine. We converse a lot, and Bill doesn't place as much emphasis on the rise of the harmonious smile line as I do. He will flatten occlusal plane oftentimes tremendously just to get the chin forward into a very straight profile. And so that's just a philosophical difference that we have. He likes a very straight profile. I like one that seems to fit the face, that also develops a smile line so that it's aesthetic. As I mentioned, you've got a number of pre-surgical considerations when you talk about determining the position of the final position of the mandible, because the maxilla dictates that. Your vertical position of the maxilla will impact auto rotation. The incisor position in the occlusal plane will also dictate the final position of the mandible and the position of the chin. The goals in surgically altering the facial skeleton are really, in my view, to get a pleasing facial balance, make sure you're happy, your patient is happy, get a functional occlusion, good surgical stability, and good TMJ health. This is not an example of a good result. This is a patient that clearly underwent growth modification. They attempted to solve what was obviously a very, very big class 2 malrelationship by blowing out the incisors. We have an IMPA that's probably in the 120 to 125 degree range. This is clearly an extraction case with the incisors being uprighted, upper second premolars being extracted, and a very large mandibular advancement. This patient still, in spite of all this, has an angle of convexity probably in the 20 to 22 degree range, whereas about 10 degrees would be something that is normal. So this is certainly a result in which the teeth came together, but the face and the profile and the dental structures are in very compromised positions. There is a very clear relationship between the occlusion and facial relationships and facial form. Occlusion and facial balance are linked. The greater the skeletal and dental disharmony, usually the greater the facial change. However, treating only the occlusion may not affect a positive facial change, as you just saw in that last x-ray. So you look at this patient and you say, this person clearly has probably an open bite. And I would expect, with that severe angle of convexity, probably in the 30 degree range, that this person should have a very, very large anterior posterior discrepancy. That would be what you expect, and that's what you want to accomplish in your pre-surgical orthodontic treatment, is to make the occlusion match the face. Well, in this particular case, that's not what happened. This patient, as you could tell, has an anterior open bite. You would expect, with this amount of crowding, with this type of facial profile, that first premolars were extracted, upper second premolars extracted, and that the open bite would be left intact. That's what was communicated to the orthodontist, but unfortunately, that's not what happened. What happened was she came back to me, no extractions. The lower incisors had been flared out further. The canines had been tucked into a position. The open bite had actually been closed somewhat. And this is exactly not what you want to have. You would really prefer to have the occlusion match the face. I would have expected for her to have 8 to 9 millimeters of sagittal discrepancy between the upper and lower arches, open bite largely the same, no vertical change in the incisors, so that we could get a very nice mandibular advancement, counterclockwise rotation, and a good occlusal, skeletal, and facial result. So it's very important when you do your clinical evaluation that you correlate your cephalometric evaluation to that patient. I will tell you, I look at very few numbers on a cephalometric tracing. They are nothing more than guides for me. I typically will look at the angle of convexity. I'll look at maxillary depth. I'll look at the occlusal plane in Frankfurt horizontal, and that's about all I look at. And the reason for that is because I'm treating the face. I want the face to look good. I don't necessarily care about what the numbers say. So I'll look at the vertical position of the incisor, the AP position of the maxillary incisor, and very, very importantly, the lower incisor angulation to mandibular plane. That is a very critical angulation of an incisor to look at, because that will dictate how much mandibular advancement that you can get with your surgical movements. And anything more beyond 90 degrees, you lose roughly 1 millimeter of sagittal advancement with every 3 degrees over 90. So if you've got a patient that has an IMPA that's 12 degrees beyond 90, say 102, you lose 4 millimeters of sagittal discrepancy. That's the width of a tooth. And that places that incisor well in front of the pagonion oftentimes, or a B point, and it can change your ability to get a good aesthetic result. You know, we don't use computer-generated predictions that often. We don't try to sell our surgical results based upon what a generated prediction would be off of Dolphin. Most of my patients are really more concerned about function. And lastly, we're going to look at dental models to make sure things fit. And we'll talk about why I segment 95%, 98% of my maxillas. So what are the aesthetic elements? Well, the teeth ought to show anywhere from 2 to 4 millimeters vertically. The smile line should really be symmetrical, and it should nicely fill the buccal corridors. And so this is a patient that's immediately post-op. The occlusal plane should rise either from anywhere from 4 degrees to about 13 degrees, depending on what the mandibular plane angle is. And to me, the facial contour angle should be somewhere between 11 and 14. But I will be very honest with you. This philosophically has changed a little bit. I am starting to put patients more in about the 5 to 10 degree angle of convexity range if the shape of the chin is correct. But the bottom line is that you need to have some degree of angle of convexity. If patients are too straight, oftentimes it makes their maxilla look back too far. It makes their chin too masculine. And this is especially with women. I've seen a number of patients that have been treated by some very, very famous surgeons who really, really like a very straight face, and they masculinize women too much, and it doesn't look good. So when we look at this particular patient evaluation, we're looking for some degree of balance, and you can see that she's about 6 or so millimeters long. We can impact this maxilla, get some auto rotation, and significantly improve her facial balance. So upper lip length on a female, around 20 millimeters, 2 to 5 millimeters of incisor display, and that needs to be correlated with lip length. If the lip is short, then the incisor display will often be a little bit more, and lower third will be anywhere from 42 to 48 millimeters. I personally like to have my patients, because of their age, oftentimes they're young, show a little bit more tooth display, usually between around 4 millimeters, but anywhere from 2 to 5 is normal. Tooth exposure when smiling can be 8 millimeters of tooth. You can have upwards of 1 to 2 millimeters of gingiva, and that's okay. You really have to look at what the patient will tolerate and what we feel will look good on them. That's the artistic component. There may be some gingival exposure at rest. If there is, you obviously want to impact the maxilla. And again, shoot for somewhere between 0 and 2 millimeters of gingival exposure. You'll have a little bit more with a really animated smile, not just their smile that they will create for you to take their photograph. And you need to make sure that you keep a close eye on the classification of occlusion. So here's just some examples. These are two individuals that worked in my office, and both of them had absolutely very, very pleasing smiles. One had about 5 millimeters of tooth display. One had about 2 millimeters of tooth display. They were both fairly brachyfacial, lower mandibular plane angle type of patients, but they both had very, very nice aesthetic smiles. And this just shows you the variability that you might see. The other thing that's really important is look at incisor dimensions. The incisors should be taller than they are wide. They should be about 10 millimeters plus or minus 2 millimeters. Their width should be about 8 millimeters plus or minus 1 millimeter. And the most attractive height width to height ratio is about 82%. So 8.2, a width differential so that the tooth is longer than it is wide. So if you see a patient like this, you're probably I would impact this patient to the arch wire, go back and have a periodontist just trim some of that gingiva to get the tooth proportions where they need to be. This is a classic example of altered passive eruption. This is actually a pediatric dentist, and all she needed was just very, very vigorous crown lengthening to get rid of that excessive gingiva. This, on the other hand, is a combination of altered passive eruption. The teeth are shorter than they are wide, but there's exposed gingiva. I would expect that the top of the tooth is somewhere here. So we want to impact the maxilla from where we think the top of the tooth is to the bottom of the upper lip. So this is a patient that we impacted about 7 millimeters. So we're going to look at facial contour angle, nasolabial angle, submental throat angle, lip chin, submental angle, and we'll look at the tooth-to-lip relationships. To me, the most important things are this facial contour angle here, basically forehead, subnasally to chin. This is your true vertical line that Arnett uses. It can vary a little bit from glabella, but he tends to put the chin right on that line. Personally, I think that's a little too straight. I will tend to put this patient, I would probably put their chin in this particular area here, probably splitting that angle of convexity to get them forward. And so the things that I think that are key in treatment planning is most ideal vertical position of the incisor and the anterior posterior position of the incisor. I will tell you, virtually 100% of my maxillary osteotomies have some degree of maxillary advancement. It may be 2 to 3 millimeters more for surgical expediency and my ability to not have posterior interferences. But if I do a extraction sequence, especially class 2 extraction sequence of upper second premolars, lower first premolars, I will always advance their incisors 4 to 5 millimeters, sometimes up to 6 millimeters, because you lose incisor support and you'll get some incisor retraction with those extraction sequences. And that allows you then to not only advance the maxilla so that you avoid posterior interferences, but then when you do your counterclockwise rotation, you have fewer interferences. you could put the incisor back in its original position pre-extraction and get the best anterior posterior movements. Oftentimes, these patients need 12 to 14 millimeters of overall chin change, and you may only get 8 or so millimeters of advancement if you're just treating the mandible alone. And even if you did counterclockwise rotation, you may not get as much advancement. So I will tell you, almost every maxilla that I perform, I have some degree of advancement. You need to look at the incisor position to midlines. It's much, much easier to correlate that now with our virtual surgical planning. You need to look at the incisor position relative to the opposite arch. Oftentimes you'll see a maxillary midline that is off and a mandibular midline that is exactly where it needs to be, and those need to be correlated. Look at incisor angulation in both arches, especially the mandibular arch, and that's so very important. Because if your lower incisors are beyond about 95 degrees, have an IMPA of 95 degrees or greater, you will have a very difficult time getting them into a class 1 canine position. And probably the most important issue of some of the transverse considerations, not only the width, but also the roll, is they're canting to the maxilla. One summer we looked at 76 consecutive double jaw surgeries that I did over about a 4-month period. And almost every single one of them had some degree of roll to the maxilla that was noticeable. It could have been 2 to 3 millimeters, upwards of 5 to 6 millimeters. So looking at the roll is very, very important, because that will tend to impact your position of the chin in the frontal view and deflect the chin if you don't take care of that roll to the side of the roll. So it's very important to look at whether you've got issues related to apical base problems versus midline issues, as in this situation. Here we've got root angle issues that can oftentimes mask themselves as a midline discrepancy. You want to look at the horizontal angle, the vertical positions of the incisors. These are probably some of the most important things that we can do. So this is just an example of a patient with really significant roll. This is a patient I did a total joint replacement on one side, the 3-piece maxillary osteotomy, and then a sagittal split on the opposite side. But if you'll look, basically once the midline didn't really change that much, but it looked off of his facial midline, because once we lengthened this side, it kicked the midlines back over to the left. And so need to correlate any roll situations with the midlines of the upper and lower arch to ensure that they end up in the right spot. It's much, much easier now with virtual surgical planning than it was with analog planning on an articulator. You can really see those changes and you can make adjustments to them. Your vertical incisor position absolutely should be limited in any orthodontic movement. If you want small vertical changes, 1 to 2 millimeters, that can be dealt with orthodontically. And you need to be very careful with the lip length. Very long lips, you will show less tooth. So correlate that. This is one of the few times that I will treatment plan to a smile line of patients with long lips and short lips. If their lip length is pretty average, then I'll treat them to an incisor dimension and vertical dimension that is mostly correlated to their resting position. Bear in mind, lips lengthen with age, and so it's okay to leave a patient a little bit long when they're 16, because by the time they're 35, their lip will have lengthened a couple of millimeters and they will begin to show less tooth. And if you left them a little long and they showed a little bit of gingival display upon smiling, by the time in their early 30s, oftentimes that's gone away because the lip has gotten longer over time. So what about your AP position of the incisors? I mentioned there's a couple different ways you can look at it. I tend to look at their nasolabial angle. I try to look at this kind of a true vertical position, and I'll look at maxillary depth just to get a sense of where I feel that incisor needs to go. But at the end of the day, I tend to treatment plan its maxillary incisor AP position in a way that it facilitates getting the chin further forward to get the angle of convexity correct, because that's ultimately what people see. But there's a number of ways that you can look at it. You can look at it via nasion perpendicular, and these are just guidelines. They're not set in stone. You really have to be patient specific and patient-centered. So you look at this patient. We saw her earlier. She's got a very significant vertical maxillary excess. We want to impact her maxilla 5 to 6 millimeters. But if you look at her incisor position relationship to true vertical line, she could actually, it's actually really in a pretty decent position. However, that being said, when you look at the position of the incisor facial surface to the inside of the lip, that incisor, when it's impacted, can actually be advanced 4 to 5 millimeters before it even touches the lip. Well, if you do that, that means you get an additional 4 to 5 millimeters of chin advancement to get the facial form correct. So we're going to want to look at the things that I will look at is also if they've got this shadow between the facial aspect of the incisor and the inside of the lip. That tells me that I can actually take the maxilla and bring it forward 4 to 5 millimeters before it even has any impact whatsoever on the shape of the upper lip. So that's really, really important thing to look at. And that's one of the reasons I think that the majority of my maxillas get advanced. So the other thing with the smile line is make sure that you get your transverse width where it needs to be. Don't forget the position of the buccal segments. Nothing looks worse than black corridors. So you want to address this transverse dimension. And I segment probably 98% of my maxillas, and I do about 150 double jaws a year, and it's rare for me to do a single piece. Largely because there's width issues, and oftentimes there are other problems related to the positioning of the posterior segments. So for me, and this is a line that I really take from Johann Rennecke, think soft tissue. Think about where you can place the incisor teeth. And we're talking about upper and lower incisor teeth to get your soft tissue goals, because that's what people see. You know, we can look at a beautiful occlusion, but if the face doesn't look right, it's not a successful case. So you want to make sure that you've got the teeth in ideal relationship to basal bone. This is not. This is a case that they took out teeth and the still proclined incisors back out of bone. These are high IMPA. This is what the face looked like. Yes, they had an acceptable occlusion, but this is a patient that really needed upper second premolars, lower first premolars, and what they ended up doing was basically just blowing everything forward to get the teeth to touch, but look at the face. This patient still has a significant retrusion. So what we want to do is get the teeth ideal to their basal bone. We want to create appropriate lip support, and we also want the jaws to be positioned in a way that we get the best soft tissue response. So as I touched on earlier, and something I really focus on is there's got to be proper lower incisor angulation. It is absolutely critical because it dictates the magnitude of all of your mandibular movements. And as I mentioned, for every 3 degrees of angulation over 90, you lose 1 millimeter of sagittal advancement. Well, that adds up. That adds up very significantly. And so what you end up seeing is individuals with high IMPAs having to have much larger counterclockwise rotations to get the chin to advance more than the incisors, or you have to do a genioplasty to get the chin in the final regional position. But the problem with doing genioplasties under those circumstances is with a high IMPA, you're going to have a deep labial mental fold because the lower lip is going to get pitched forward. So it's a very big compromise. And so I'm very, very adamant to my orthodontic colleagues that we need to ensure that that lower incisor angulation is where it needs to be. And typically speaking, I'm looking for a 90 degree, no more than 95 IMPA. And just think about this. If this patient's kick is a class 2 and this is rotated forward, you're never going to get the chin where it needs to be. The other thing is the higher that this angulation goes here, the more the lip goes forward, the deeper the labial mental fold, and it makes the chin shape look exaggerated. All right, so we want to make sure that we get those incisors decompensated. And in my view, it is the major contributing factor to getting an aesthetic and functional outcome. And it also implicates long-term stability. If you've got incisor teeth, any teeth that have been expanded beyond their biologic capability of maintaining stability, then you're going to find you're going to have relapse. And where we see this most is on the lower anterior teeth, where they've been pushed out of the buccal trough of bone. They have a thin, oftentimes thin biotype and thin periodontal situation that can cause soft tissue problems and lead to tooth loss. So what we have found is that it is critical to make sure that not only do you have alignment of the teeth, but you also have coordination of the arches, but also the things I stress the most is decompensation in 3 planes of space, with the sagittal decompensation being the most critical, because that's going to dictate your surgical movement. So this is a case that I looked at before surgery, and the orthodontist said they're ready. And I said, well, let's do this. Let's see if we can't take some teeth out. Let's retract these incisors back a little bit. Let's get a bit more sagittal discrepancy. The orthodontist completely ignored me, sent the same patient back saying, hey, they're ready for surgery now. Look at those incisors. Look what's happened to the lip. The curvature here's gotten worse. Now the incisors are significantly behind pagonion. This is a case that absolutely, positively needed upper second premolars extracted, lower first premolars extracted, and a 10 millimeter advancement. This patient actually never came back. They were so frustrated, they just took the braces off, and we never operated on this patient. But this patient had a lower incisor angulation that was 122 degrees. That's 20 degrees. That's about 8 millimeters of difference between where we were here and where they ended up when they were, quote, ready for surgery. And I'll be honest with you, if you look at the literature, it doesn't, getting adequate decompensation is sometimes a challenge. It is about 80% of the time they'll get decompensation. We looked at 100 consecutive bimaxillary cases in about a 7-month period. And what we found is what I basically told you, is that we found that that we rarely got full decompensation of the incisors. As a matter of fact, if you looked at our data, 59% of our patients, 60% altogether, and what was important was that 72% of our class 2 patients had incisor positions that really limited our ability to get as much mandibular advancement as we possibly could. And so what we found was, as I just mentioned to you, if you were to take and upright the incisors, you would get 4 more millimeters of mandibular advancement in a case such as this, and you would then not have to do any type of genioplasty. So it was this very set predictive ratio that every 4 degrees, I think I mentioned 3 degrees earlier, but it's 4 degrees. Every 4 degrees of change in the IMPA equals 1 millimeter of change at pagonion. So you've got 12. If you've got a patient with an IMPA of 102, you've just lost 3 millimeters of advancement. So it's really, really important that you be mindful of that. And as I touched on a minute ago, it's the prevalence is really exaggerated because it actually occurs in the patient population that you really don't want it to occur in. It's okay to have a bit of forward inclination on a class 3 because you're oftentimes advancing the maxilla. You're increasing the magnitude of those moves, and it's not as big an issue, except it's a little harder to get the teeth to couple. But in a class 2 patient, it is really challenging. So, make sure that your lower incisors are appropriately addressed. So, as I mentioned, you get deepened labial middle fold, you get a procumbent lower lip. There's a very high probability of poor occlusal coupling, and there's a lack of appropriate chin shape and projection, just like in this particular situation here, where what did I have to do? I mean, I hate this chin. I mean, her chin's too prominent. But if I'd have advanced her just a tiny bit, she would have been still retrusive. This is a compromised case in my view, and I'm not particularly happy with it. Facially, she didn't look too bad. It's better than what we started with, but it could have been so much better. So let's take a look at some of these patients. If you just do that retraction of those lower incisors, and you can see how much you improve the magnitude of the movement. Now, you notice what happened with these incisors. They dropped back. That is another reason that I will advance the maxilla if needed to get the best facial form. So extractions are not bad. You can overcome some of the problems with that. But just by changing that, it's double the amount of mandibular advancement versus a patient that has an IMPA that's been compromised. The other thing that's important is the transverse discrepancies. I think one of the most challenging things that we do is widen maxillas. It's unstable. We tend to see more relative discrepancies with class 3s. And I think in this group of patients with transverse problems, it's probably better to treat patients when they're young, because you can do some dentoalveolar molding with expansion. But there's just an example of a class 3 that's got a crossbite. But when you bring them more forward into more of a class 1 relationship, that crossbite goes away. So it's more of a relative crossbite. Here's an example of an absolute crossbite. This is a patient that would benefit from a SARPI. So there's just a difference in classification, but it's important to recognize them. Here's just an example of a patient that we needed to get these canines into position. We didn't want to take out teeth, and so we managed his situation with the surgical route. So you've got the 3 different options. Early, you can do orthodontic expansion, kind of early treatment where you don't want to take teeth out. You can do a maxillary expansion or a SARPI, or I call them the same procedure. Or you can do a segmental maxillary osteotomy if it's small refinements with reasonable arch form. So this is just a flow chart kind of showing you what you can, how you can address various arch width incompatibilities. Typically orthodontics alone, you're going to do it young. This is my daughter when she was just a small girl, probably 5 or 6 years old. Transverse discrepancies, big teeth, narrow arches. We did an expansion on her and widened her back out, and she then put her back in orthodontics, and she eventually had a mandibular osteotomy just a few months ago. But here's just an example of some of these patients with significant skeletal arch incompatibility. They're usually long, narrow faces, narrow stenotic nasal passages. Teeth that are ectopically positioned, very thin, narrow alveolus. These aren't very good patients to take teeth out on, but you can do a SARPI on these patients and pick up enough room to get these canines into good position. And some of the associated findings are oftentimes some differences in correlation with vertical maxillary and AP problems. These patients that have really constricted maxillas usually are class 3 and usually are very, very narrow. One of the things that's very, very important is if you're going to do distraction osteogenesis or a SARPI type of procedure, you want to do that early. You don't want to have teeth activated orthodontically. You want to get as much surgical widening as you possibly can to try to address that. But when it comes to a segmental maxillary osteotomy, you also want to keep these teeth upright so that if you tip these teeth, you don't get the changes at the lower fort 1 level that you normally would that you want to try to avoid. The differences between surgical assisted maxillary expansion versus a segmental maxilla is just that you get different patterns of transverse expansion. A SARPI or SAME, you get more expansion at the canines because everything's activated up front. Segmental, you're going to get more expansion at the molars, but some expansion at the canines. So typically, I'll do a maxillary expansion if the discrepancy is significantly greater than 5. There's been failed orthodontic expansion. Clearly, if there's a very large expansion and they're young, then that's where we want to do our SAME procedure, our SARPI procedure, and if they've got nasal stenosis. You want to try to relieve all of the buttresses, specifically the zygomatical maxillary, and I always will separate the pterygoid plates. I like to have maxillas that are really, really, really mobile when I'm finished, and I'll go down the midline. The other thing that I do is I duplicate my proposed Lefort 1 osteotomy lines, because often these patients are going to be back for a secondary procedure. And so I don't do the standard straight line cut in any Lefort 1. I think that's a really poorly designed osteotomy. The way that I do it, as we'll show you, is more horizontal and then angular, and I think that it really makes a much better result, and you get more effective expansion, and you get really good healing. So as I mentioned, I make my Lefort 1, my assisted axillary expansion cuts very similar to Lefort 1. And then we'll do a very straightforward expansion with those, as you are all very accustomed. The other thing you need to be careful of is tooth mass problems. A lot of patients that have corrective jaw surgery have bolt-in discrepancies. And so you need to do one of two things: either open up spaces distal to the upper laterals, do interproximal reduction with your orthodontist preoperatively to try to address some of that. You may have to segment the maxilla, which I typically will do. And sometimes you actually even have to overcorrect the mandibular position, IPR on the lower, and then retract teeth. But this is not advised. This ends up taking a long period of time. Your patients have a very unstable occlusion if you overcorrect. And so it's much better to deal with things preoperatively. But really, ideally, with the bolt-in analysis, you want to place those incisors in the best position possible and get those discrepancies identified and dealt with orthodontically before you do anything. You may need to open up the incisors with a little coil spring, but hopefully you won't have any issues. But at the end of the day, you need to take into account what the final incisor position is going to be if they've opened up space distal to the laterals. Because what will happen is you'll open up space, you'll procline the upper incisors, you'll treatment plan them to that maxillary incisor position, only to realize that the orthodontist is going to pull those incisors back to close the space. So if you've got space distal to the laterals, account for that in your maxillary advancement, so that if they close those 2 millimeters, you don't lose 2 millimeters of lip support. Very important to consider that. So here you can see we've advanced this mandible, and we're still in the end-to-end occlusion. So what do you have to do? You have to open up this space here so that the incisors are no longer an impediment to getting the mandible into a class 1 relationship. So just examples. This is what you can accomplish with a non-segmented maxillary osteotomy, end-to-end occlusion. So you're back to doing post-surgical finishing. If you segment behind the lateral, which 99.9% of all my maxillary osteotomies are segmented behind the lateral, you can open up a small amount of space, and you can get that the incisors re-angulated, get that vertical dimension where it needs to be, and get the canine into a proper position. And here's just an example of a patient that, here he is. That's what his maximum advancement would be. We just lined up his canines and overcorrected his mandible. And here he was pre and immediately post-op. You can see I've overcorrected him to end-to-end. IMPA is way too high. So we went back and did IPR, elastic, class 3 elastics, retracted those teeth. And you can see we're still fighting a little bit of an end-to-end occlusion. This one's better. This one's not as good as it could be. Significant compromise in my view. Another example, this amount of space, almost impossible to open up surgically. You can always do it on the models and never do it in reality. So here's just an example. Her head's not in the gantry very well, but you can see set her up end to end. And then 8 months later with elastics, kind of settled her into position. Not a very good way to do things. So don't ignore tooth mass issues. So what are some of the surgical controls of incisor position? Well, first of all, you can control vertically by maxillary impaction, or you can downgraft it. You can have vertical control through segmentation, where You leave the posterior segment where it needs to be. For example, if this patient's got incisors buried up underneath the maxilla, you can bring the incisors down a little bit if they'll tolerate it. If the incisors are in a good position, you want to leave it alone, and you take the posterior teeth up. So you've got a tremendous amount of control over that aesthetic four-tooth segment just by utilizing a segmentation scheme, because you can control the angle, vertical control, and you can also control posterior segment control as well for canting, and as well as to invoke a little auto rotation. So the issues that I have with a single piece maxilla is you can only do two-dimensional corrections. So what's that mean? That means that you have to accept everything that the mandible gives you, because it's got to fit perfectly there. If you've got multiple occlusal planes, which we often see, especially with open bites, you can't correct that. You can't correct transverse differences because you can't change it. You can't change the smile line or manipulate it from one side to the other if you've got canting. The usual movement for most single-piece maxillas with open bites is usually a posterior impaction with auto rotation. And the problem with that is you can't control the final incisor angulation at all. I mean, basically what ends up happening if you use this scheme to close the open bite, the posterior maxilla goes up, the incisors angulation gets a little bit more upright, so it's a little bit more arbitrary, and it just really doesn't do you a lot of good. So if you look at this animation, you can see exactly what happens. We're uprighting the incisors, we're lifting the canines off the occlusal plane, and we end up with a big posterior open bite. The other thing is you're also tipping the base of the nose forward. And as you tip the base of the nose forward, you're getting alar base widening. That can be really, really unesthetic. So this is just an example. This is a patient that I did a revision on after she had a 2-jaw procedure. Her occlusal plane was steep to begin with. Her mandibular plane was steep to begin with. They impacted the posterior maxilla. They uprighted the incisors. They made the occlusal plane even steeper. They actually made her airway even smaller, and the base of her nose got bigger. And so in this case, I basically reverse engineered it and just rotated everything in a counterclockwise position to keep chin in the correct position, rotate nasal base back, do a nice alar base sense suture, and that solved her aesthetic problems. The other issue with single piece maxillas, this is a patient that developed a large open bite after orthodontics because they had significant expansion done of the upper and lower arches, and then it relapsed. And so I will almost invariably segment maxillas. So you need to be very, very careful with your transverse dimensions, and very careful with single piece maxillas. I think that with segmentation, you improve the final occlusion, you control the transverse, you get three-dimensional leveling of the maxilla. It absolutely decreases orthodontic treatment time. But you have to be careful because if you get expansions and tipping and overexpansion orthodontically, it can be a very, very big challenge surgically for you. And as you can see here, you want to keep orthodontically those teeth upright, because if there's any tipping to the teeth when you do 5 millimeters of expansion at the lingual cusps, if those teeth are tipped out, you can get 10 or 11 millimeters of expansion out here at the midline and at the buttresses, and things just don't fit right. And this is an example. This is a patient that we did a 3-piece maxillary osteotomy on, and you can see that I make my horizontal cut parallel to the occlusal plane and then angle it at 90 degrees to the buttress. We leveled this side. This side didn't need leveling. This is a side where the teeth were tipped, and by the time we widened her, those were the gaps that we got. We got 4 millimeters of widening down here and 10 or 11 millimeters of widening up here. If they'd have kept those teeth upright, this gap would be half of its size. The segmentation options are basically 3. You can use a midline segmentation, which I never do. I only do that on a Sarpy because what happens is you get too much widening at the canine in relationship to the molars. You also can begin to tip those teeth and change the root angulations if you're not careful as well. So I tend to not do single P or midline widening whatsoever, in large part because of what the changes you get here and the changes that you get in relationship between the canine and the molars. Canine premolar, I probably do one canine premolar case every 4 or 5 years. And it's usually because that's the natural step in an open bite. For example, the bone's thicker. There's some inherent problems with it. One, it requires unnatural root divergence and allows, but yes, you can get differential impaction from the premolars back. You can still control the anterior, but oftentimes the problem is that you tend to want to put this incisor down on the occlusal, down on the bracket, and it lifts the canine off the occlusal plane, uprights the incisor a little bit, and it can oftentimes limit the way that your anterior segment fits because you can't change the canine width. The other thing that it changes is the nasal base. Because you're segmenting this, if you advance this or if you tip it, you're again going to get changes at the piriform rim, which can be unesthetic. So it's rare for me to do a segmentation behind the canine. And you can see kind of what happens here as it lifts this canine up off the occlusal plane. And even if you do a little bit of impaction here, you're going to be limited by your contact there. So it limits your movements dramatically. So I'm more a canine lateral incisor segmentation person because of tremendous amount of flexibility. You can control absolutely everything. Any segmentation has the potential for complications, but they're extremely rare if you use a good technique. And to me, I think this is the most important thing is you get canine width changes where you can resolve bolt discrepancies, and you can see that you can change the widths of the posterior segments, the vertical position of the incisors very nicely. You can either re-angulate the incisors or leave them alone. Lots and lots of flexibility there. And you can see just an example of the cuts are within the piriform rim. These small areas can be grafted. This is a plate that I designed that I use that fits my segmentation scheme beautifully, and it doesn't have any impact on the nasal base whatsoever. And so my multi-angular design I think is real important for this particular resolution of maxillary problems. And you can see that I don't make cuts that go straight down. I don't use the Wolford technique. I tend to use my technique because I get a lot better adaptation at the buttress, and you can see all of the different ways that you can move the maxilla when you use this segmentation scheme. You can correct everything in 3 dimensions. It really works very nicely. And it's an osteotomy that I developed, really kind of an adaptation of Wolford's technique. Wolford goes straight out and then he drops down. The problem with that is the plates at the buttress are very precarious, where here it's really dense. And as you'll see, with the technique that I use the saw across the anterior maxilla, and then I place it at 90 degrees to the buttress, and I angle it down posteriorly. And I angle it inward so that I'm actually cutting this on a mortise, if you will, and it really makes that maxillary cut very nice, especially if the bone is very thick. All you have to oftentimes do is do light relief of the bone here to get absolutely beautiful adaptation. Whereas if you make that cut straight through, you're going to have no contact at all. You're going to have a gap there, and this just allows for greater stability. You're able to get beautiful adaptation of the osteotomy sites for plating, and I think it's really key. I'm going to we'll finish up talking about my segmentation technique, But I think one of the most important instruments in my armamentarium is something that most people would find on a golf course, and that's a little pencil. This little pencil does a lot of things for me. It allows me to highlight the shapes of the roots and then make sure that I've got good converging angulations. I do my segmentation after down fracture because that allows me to see all of the geometry to ensure that I can move that 4-tooth anterior segment. So I mark the roots, I mark my line of osteotomy, I take a 701 drill and I make a small kerf, a small cut above the roots that goes into the nasal floor. I then use an oscillating saw with my finger on the palate to feel that join the horseshoe-shaped osteotomy in the floor of the nose. And then I use a periotome down between the teeth, and I just gently tap just a few millimeters through that cortical bone, and then I'm able to take a wood-handled osteotome, and it will separate. And once I've separated it, I'm able to mobilize it. And this is just what the little periotome looks like. Then I can just separate that. I use this wire here to help wire that segment if I'm pulling it down hard for an open bite closure. And then I use that hole that wire is passed through to suture the alar base to in all my muscle closure. The palatal, I usually will use a horseshoe-shaped palatal osteotomy because the soft tissue is thicker, but you can do palatal releases. My good friend in Salvador, Lucas Esteves, sent me this slide. But we use the same exact technique of just a small palatal incision, as you can see here, undermining the soft tissues in a way that allows us to get relaxation. And then in these cases, I will go down the midline. Because I've undermined that and I can make that cut without damaging the soft tissue. And then you can put bone graft material here, but you need to be very, very careful. I've seen this extrude through the palate, so be very careful with that. And then I use a little palatal splint to hold the position. This is more often the technique that I use, and this is what Igor and my friends from Brazil who've come to visit me will often see me do. And then I stabilize it with the system that I've designed because it's a 1.5 millimeter system. It just fits very, very, very nicely. So what are the disadvantages? Yes, many, many years ago, we had a tooth fracture, but that's the only tooth I've ever injured in over 3,000 segmented maxillary osteotomies. It takes about 10 minutes to do the segmentation. My entire Le Fort 1, I can have down fractured, segmented, splint in position, ready to reposition, and plate in about 20 minutes. So it's very, very quick. You can have issues with tooth devitalization, but in all honesty, I've had 1 or 2 teeth that I've actually had patients get root canals on. It's very, very fast. It's important, I think, to realize that you can manage the maxillary deformity in 3 dimensions very, very, very nicely. Just here's some examples of patients we did segmental osteotomies on to stabilize their bite, some with and without. This is just an example. You have beautiful tooth to lip position. So in her case, I brought the maxilla down just a tiny bit, just to make her smile line show a little bit more tooth. And you can see I used that wire to hold that vertical dimension and hold that into position. You'll notice I didn't plate the 4-tooth segment. We just drug that down. So I'm going to summarize at this point and just talk about why I think it's really important to have the maxilla and the lower incisors in the correct position, utilize segmentation, utilize rotations, is because it really drives all of the aesthetics. And the last thing that you really want to do is utilize a genioplasty. A genioplasty, in my view, is never a substitute for getting the proper advancement to optimize the final facial form. It should be the cherry on top that is utilized really just to change the shape of the chin, maybe lengthen the chin or shorten the chin or deal with an asymmetry. The chin, if it's got a good form to it, should not be thought of as a way to get the mandible into the best position for facial aesthetics. It should only be used once the lower jaw is in the correct position to change the shape of the chin, to add that final bit of aesthetic optimization to it. So keep a very close eye on incisor positions. Look at rotational movements as an adjunct to improving facial form and getting the chin forward. But the incisor position is very, very critical in doing that. Save that genioplasty for the cherry on top. And with that, I'm going to conclude, and I appreciate the opportunity to have joined you today. As things open up with COVID, feel free to contact me. It's always a treat to have my Brazilian friends come and join me for a few days and watch surgery and hopefully take home some little pearls that I have gleaned over my 30 years and thousands of double jaw surgeries. And you can take those things home to your patients, and hopefully they will benefit from them. Igor, thank you again for the invitation. Thank you for your attention, and we have a very good meeting.
Hello, Professor. I'm Leonardo, or just Leo. Can you hear me?
Yes.
Professor, thank you for your attention, and congratulations for a nice lecture. It was outstanding. And I'm sure that all of participants learned a lot from you in this morning. We have some questions in chat. Can I read for
yes.
you?
Yes.
So the first one, to determine the final position of the upper incisor on the profile view, do you use some specific analysis? Just like an Andrews line or nasal, just the eyes. I know, that's okay.
Yeah, no, I mean, here's the position. Okay, I use angle of convexity. You know, what's I think really interesting. Bill Arnett called me a week or so ago. He goes, "Please use my software. I think you'll really like it." So we did my analysis. We did Arnett's analysis. I knew where he was going to put it. I predicted in advance there would be about a 2 or 3 millimeter difference in where he put the chin position and where I put the chin position. I used angle of convexity. We used his analysis. And what was interesting is he's very strong on head position. Okay. But he's not really very strong on head position, because in the course of our online meeting, he changed the head position to reflect his view of the occlusal plane, only to get the chin further forward. You're shaking your head. You agree? Well, what's that? What does that tell me? That tells me that the head position doesn't matter. Sure. It doesn't tell me it doesn't, because really, and we're going to look at these, because Bill Arnett, great guy, love him to death. He treatment plans most patients to a 0 degree angle of convexity or no more than 5 degrees. If you know that angle, head position makes no difference.
Sure.
None at all. So if I say I want an angle of convexity, and a lot of times I'll look at a patient and I'll go, your chin belongs here. This is going to give you the best profile. I look at that angle of convexity, it's between 5 and 10 degrees. I'll do that by eye.
Yeah.
And then we do our analysis, and guess what? 90% of the time I'm right.
Nice.
You know, so I use angles because head position doesn't matter. And so the incisor position only makes sense if you couple the occlusion and rotate until you get the chin position in the position you like, the vertical position of the incisor that you like. That will set your AP position of the incisor, because that dictates the final position of the chin, unless the chin's really, really straight. So then we'll look at that. We may factor in a genioplasty of 3 or 4 millimeters to change the chin shape, and then advance to our line that we like. and that'll dictate the position. Keep in mind, anytime you do a counterclockwise rotation, when you bring the incisors forward and you rotate them back, the base of the nose, A point, all goes back to where it came from. Okay? I can look at a cephalometric x-ray on a high angle class 2. I can see where I want the chin. If that is 12 millimeters forward, I'll look at the overbite. If that is 6 millimeters, I need 6 more millimeters somewhere else. Okay? If I advance the maxilla 3 millimeters, now I'm up to 9 millimeters of change.
Yeah.
If I bring it down 3 millimeters at the molars, it's almost a 1-to-1. So if I need 12 millimeters, I have 6 millimeters of overjet, automatically I'll start my analysis and my treatment planning with 3 millimeters of incisor, 3 millimeters of rotation, downgraft, plus my 6 millimeters. Almost every time, it's right on.
Awesome.
Very simple. It's pattern recognition. You don't need 50. Bill Arnett's got 53 points on his analysis. 53. I have 3.
Nice.
Very simple. And we get the exact same result.
When you have a down fracture and we need to inferior reposition of the maxilla, what kind of bone graft do you use? Autogenous or?
Depends. I mean, you're talking about anterior grafting. A lot of times just freeze dried bone.
Okay.
Or if it's a class 3, I may take some bone off of the segment and put up there.
Yeah.
If it's a young patient, they usually do pretty well. Then you can. I'll even use, if it's a small defect, less than 3 millimeters, I'll just put Vitas in or some material like that.
Okay. Another question is, in situations like you showed that the mandibular incisor before surgery is much more pro-inclinated, like a high buccal inclination, how is your surgical planning? Or you're just send the patient back to the orthodontist to correct the angulation?
Yeah, I try to do that in advance. Is try to do that all in advance if I possibly can.
I know. Professor, and one question from Professor Fued, Dr. Fued from São Paulo, from São José dos Campos. Have you any experience with minimally invasive orthodontic surgery?
Oh, you mean like Alfaro?
Like Alfaro, yes. Sure.
Small surgery, small movements.
I know.
To me, it's a gimmick. Okay, let me ask you this. How can you possibly do large surgical movements through tunneling incisions? How can you possibly do 3-piece segmentation through tunneling incisions without a formal down fracture?
It's hard. It's hard for me.
I don't think it's possible. I think there are very, very few indications for that. I think it's a little bit of a gimmick. I mean, Igor has seen I do a double jaw surgery in 1 hour and 30 minutes.
Wow.
Nice. So I mean, to me, that's pretty minimally invasive. I mean, they're not having a long anesthetic. They're not having a lot of blood loss. Yes, it's a larger incision, but you're still degloving the maxilla either by tunneling or by reflecting. So I just think that it limits your ability to appropriately treatment plan patients.
Okay. Just one or two questions.
Yeah, one more question. Yes, I've got.
Oh, okay, that's okay. Nice. Oh, in case if you have a great movements of the occlusal plane angle, for instance, in large upward and forward rotations, is there condylar chains in immediate postoperative or in the long term in your experience?
Well, you mean like with a maxillary impaction?
Yes,
but those are favorable movements. To me, that's a very favorable movement. When you impact the maxilla, you're getting some degree of auto-rotation, and that mitigates the amount of posterior downgraft. So to the answer to your question is yes, there's always condylar changes. There's condylar changes in a 5 millimeter sagittal split, but are they clinically significant? It's the big issue. This is another Arnett story, but we mapped a group of my patients, and I use position screws and I use a clamp to segment it, and that's sacrilegious in Bill Arnett's world. But at his orthodontic surgery forum, I presented our results. We didn't see any changes that were significant using a clamp and using position screws rather than plates. What we saw were just adaptive changes, and those were patients that were class 2s and class 3s. But that being said, they all had some degree of change. Mind you, it's very small, 0.5 millimeter. Usually it's very adaptive. You can't predict when you're going to have big condylar changes. They just happen sometimes. I got a patient in a week, just this last week, that I got final records on, and she was a big counterclockwise rotation, joints completely asymptomatic, very nice occlusal result, and she had perceptible changes in her condyles on CT scan, but they were asymptomatic.
Yes.
So, it's very difficult to predict condylar changes.
Okay.
Other than they're going to happen.
Dr. Sullivan, thank you again for your time, sharing with us your experience. And we hope to see you in person, or for me to meet you in person soon. And we would like to thank you again and have a great day ahead. And if you have some words, or if Dr. Igor has some another words to ending or our time, or we can finish now.
All right.
Oh no, we can finish. Thank you again, Professor.
Have a great day. Have a good meeting.
Have a good day. Pessoal, então, vamos terminar por aqui, agora em português. Mais uma vez, agradeço pela oportunidade a todos os organizadores da Universidade de Guarulhos, a professora Elaine, o professor Igor, todos que participaram. Tenham um ótimo dia. Muito obrigado.
Obrigado, Leonardo. Muito obrigado pela sua moderação aí.
Eu que agradeço.
Eu acho
obrigado,
que
viu?
Fantástico.
Foi um prazer estar com vocês.
Show! O nível da palestra foi altíssimo, foi um prazer também te conhecer, Léo. Muito obrigada.
Espero encontrá-los logo.
Você aí, né?
Não sei se está aberto ainda, já encerrou? Érica, já encerrou?
Está mostrando ao vivo ainda, né?
Ah, tá, ok. Eu acho que...
A gente se fala pelo WhatsApp, então.
Tá bom.
Muito obrigado, viu?
A todos, obrigado por terem participado.
Ótimo.
Muito
Um abraço a todos.
Grande abraço, um bom dia a todos.
Um abraço.
Um bom dia, um abraço a todos.
Um abraço.